big thanks to all of you for sparing your time. The first day of the webinar was indeed quite interesting. And you're all welcome to the second day of the webinar. And I think it will be even more engrossing as the lecture topics today are more clinically oriented, that is, real-time practice related. Moreover, the panel discussion will talk about integrated healthcare for patient management, which will give us an insight to the clinical challenges we all face in our setups. So now I would like to invite our esteemed moderator, Professor Dr. Sangeeta Dheer, to initiate the meeting. Over to you, ma'am.
Thank you, Dr. Sumedha. We have some of the new delegates and faculty members who have joined. So just we're taking a few revision from yesterday. Can we have the Diabetes India AV PPT that we had created for our viewers? We are about to begin the session 1 of the day. The chairpersons for this session will be Dr. Srihari and Dr. Saurabh Srivastava. So can we have the introductory slide for Dr. Srihari, please? Professor Colonel Dr. Srihari AK is MDS in Periodontology and he heads the Department of Periodontology at Army Dental Center Research and Referral, New Delhi. He has done his MDS in Periodontology from AFMC Pune. He has served in different medical and dental units of the Indian Army and Indian Air Force. He has been a principal investigator in Army Forces medical research projects and has numerous publications to credit. Can we have Dr. Saurabh's bio sketch, please? Professor Dr. Saurabh Srivastava is a professor of medicine and chief medical superintendent at Government Institute of Medical Sciences, Greater Noida. He has a special interest in diabetes, endocrinology, and critical care, and has been awarded GB Jain Oration at IACM Con 2014, awarded the Padmaka Tripathi Award at UP Dakon 2015, awarded Investigator of the Year Award at BP Con 2017-18. He's a secretary of UP Diabetes Association. He's a joint secretary of RSSDI UP chapter. He's the associate editor of IJJDC. He's a secretary to editor. He is member editorial board and is a international and national publications innumerously with the contribution of textbook chapters. Now I please request Dr. Srihari to please introduce the first speaker of the session, Dr. Manoj Chawla, please. And can we have his bio slide?
A very good evening to you all, to one and all. Thank you for the kind introduction, and I also thank Dr. Sangeeta and all the organizers for giving me the honor to be part of this webinar covering a much discussed and present day relevant topic. Now, the first speaker for the day is Dr. Manoj Chawla. He is the director and consultant diabetologist in our diabetes care and Mumbai Diabetes Research Center. And he has been an elected All India Executive Committee member RSSDI in 2022. He is the scientific chairman of Diabetes India and organizing secretary of the Diabetes India. And he has been an honorary visiting faculty at the D.Y. Patil Medical Sciences in Navi Mumbai. And he has been awarded RSSDI Fellowship of the Royal College of Edinburgh. He has been the principal investigator in various global MNC clinical trials of devices. And he has been a technological task force member of the RSS DI and more than 25 papers in national and international journal. And he is the associate editor of the International Journal of Diabetes in. And now I request Dr. Manoj Chawla, please start with the proceedings of the day.
Thank you. Thank you, Dr. Shriyari, and good evening, everyone, again. And as I did say yesterday during the inaugural session, many congratulations to the team involved. I've been asked to speak on diabetes and oral health clinical learnings or clinical evidence from a physician's and diabetologist's perspective. Let me start by sharing my screen here. Okay, I am going to be speaking about the diabetologist clinical experience, the lacunae which happen even in today's times. A little bit of course, theory. I believe a lot of this may have been discussed since yesterday. So I will take the liberty of rushing through the theoretical part, but essentially then leaving it open for discussion on what's missing and what's improved in the last few years. So there continues to be a bidirectional relation between diabetes and oral health as we understand today. Both are related due to common milieu of risk and causative factors. There are multiple oral health-related conditions associated with diabetes today, be it periodontal disease that we largely speak about, and the entire spectrum of the disease segment there, gingivitis, dental caries, tooth decay, tooth loss, burning mouth syndrome, halitosis, lining up with even the link with cancer and so on. So what about periodontitis? So it's an oral gum disease or pyorrhea that gets characterized by inflammation of the soft and or hard tissue surrounding the teeth, initiated by the bacteria in the plaque on the teeth near the gum line and promoted by the host immune system. In 1993, periodontitis declared as the sixth complication of diabetes. It still took a long time. 2 decades later, the medical community has taken notice and subsequently generated some scientific evidence to support the theory that actually periodontal infection is a risk factor for uncontrolled glycemia. And we were largely unaware or blind to this aspect, realizing that it also increases cardiovascular risk and complications for adversely affecting the outcomes. Well, that's how a normal periodontium looks like. It's not for the dentist here, it's for us physicians who often forget what a normal tooth or periodontium looks like and the different stages of periodontal disease from healthy teeth and gums to gingivitis to progression to more advanced periodontitis. Now, the entire spectrum starts with a plaque, which is an adherent biofilm of microbes and food debris, which gets attached to the tooth surface. The plaque buildup is seen even in those who brush teeth regularly, but not correctly by not removing the plaque or not brushing good enough. Gingivitis is at a stage where it is reversible and inflammatory reaction caused by dental plaque accumulating on the teeth. In susceptible persons, the untreated gingivitis will actually gradually lead to chronic periodontitis purely because of poor oral hygiene and not being aware of the early presence of this condition. Somebody reaches a stage of chronic periodontitis, there will be severe irreversible affection of both soft tissue and bone support around the tooth. Major cause of tooth loss in adults, requires lifelong monitoring, and severe periodontitis affects 10 to 15% with considerable variations in epidemiological data that we have today. You also have periapical periodontitis affecting the jawbone. Now, you look at the prevalence of moderate or severe periodontitis, and you will see here that there is a direct connect with the levels of glycemic control. So when you compare in three groups, which is normal glucose levels with an A1C less than 5.6, those in the control pre-diabetes or control section, which would be 5.7 to 7 HbA1c, and then those would stay more than 7, you will see at all age groups a direct connect, which is linked to the different levels of glycemia. With as the A1C rises, there is higher prevalence of periodontitis in this group. You will also be able to appreciate the difference between men and women. Both in men and women, again, you will have the similar aspects of linkage with worsening A1C, but you see a slightly higher prevalence in males as compared to females, with other factors as race, ethnicity, and smoking status also being significant drivers to the presence of periodontal disease. You look closer at home for us between diabetes and periodontal disease. Hyperglycemia adversely affects the soft and hard tissues of the periodontium. Prevalence of gingivitis, further worsening and leading to prevalence of moderate to severe periodontitis. More than 2 times prevalent in those with diabetes as compared to non-diabetics. More than 3 times in those between 30 to 44 years of age with poorly controlled diabetes compared to those without diabetes in a US study, and more in men as compared to women at all levels of glycemia. There are 3 pathogenic mechanisms which link diabetes to periodontal disease. Essentially, the inflammatory response. So the inflammatory markers and mediators which you originate from the inflamed periodontium will lead to presence of bacteremia originating in the oral biofilms, which is the part of the plaque. And then they generate or cause about an immune response, which will lead to the cascade of events, creating the generation of oxygen-free radicals, worsening of glycemia, release of more immune inflammatory markers, and the linkage even with vascular complications. These are links which have been well demonstrated. I'm not sure this has been shown since the multiple talks since yesterday, but here we talk about the presence of plaques eventually leading gingivitis, leading to periodontitis, leading to the release of immune inflammatory markers, causing a milieu of insulin resistance, hyperglycemia, oxidative stress, and there has been demonstrated direct link in this to even other microvascular complications of diabetes like diabetic neuropathy. Again, a pathway which talks about how an inflammatory response in the presence of bacteremia will lead to an immune response, which will cause release of immune inflammatory markers and will actually affect the vasculature, the heart, the joints, the brain, the pancreas, of course. So sometimes this may be actually also a cause of onset of diabetes. Today, we understand that diabetes has a genetic preponderance, and usually the onset will be brought about by an environmental insult, which very often can be periodontal disease as well. You look at peri-implant disease. So quickly, other links between diabetes and other oral conditions that we come across. Tissue disease around the dental implants, especially in people with diabetes, this is a problem. You can have peri-implant mucositis, which will be called gingivitis. You will have much worsening of this inflammation leading to periodontitis, loss of the soft or hard tissues, and also the complete implant at times. And all of this is adversely impacted by poor glycemic status. Common problem, diabetes and dental caries. You have 2 types of caries, the coronal caries and the root caries. Both untreated caries lead to death of the tooth, decaying the interior soft tissue called the pulp. The global burden of this study says that about 35% global prevalence for all ages taken together. You also have a link with the periapical lesions. I mentioned that briefly earlier, that those with diabetes have a greater risk of the periapical lesions in the jaw bone. Periapical lesions is a complications of diabetes. Symptoms can include pus coming out in the oral cavity or the oral mucosa, and rarely an abscess which may drain into the neck. Sometimes in the past, this has even been misdiagnosed as cold abscesses, but a closer look or the right kind of physician or a dental physician checking there can pick up the presence of periapical lesions. You will have link between diabetes and early tooth eruption. Children, especially girls aged 10 to 14 years with diabetes, experience accelerated tooth eruption. Malocclusion, impaired oral hygiene, periodontal disease, caries due to the prolonged exposure in the oral cavity are all consequences of the same. Besides, caregivers may not notice first molars erupting behind at this age, precluding the oral hygiene measures. The other common problem that you come across in diabetes is dry mouth due to hyposalivation. This may be because of pre-existing diabetic neuropathy, persistent hyperglycemia causing the dryness, osmotic symptoms like polyuria, sometimes radiation given to the head and neck without proper protection. Some medications can cause that slow salivary flow in children, especially with type 1 diabetes. Xerostomia, which is feeling of dry mouth, is in fact not directly related to hyposalivation. So patients may not very often complain of any of the symptoms, and this goes unnoticed. Then a direct link between increased prevalence of tooth loss in people with diabetes. Missing teeth or hurtful teeth will disrupt the normal eating, and hence patients modify their eating behavior, sometimes eating only more fruits, the softer ones, mashed food, typically in India, more rice, more curd rice, and many of the other food items which actually have high glycemic index, in turn leading to worsening of glycemia. Diabetes and fungal infections, especially candidiasis, have always had a link there. People with diabetes experience more oral candidiasis or thrush in presence of poorly controlled metabolic status. Diabetes does cause delayed wound healing, and it's no different for oral wound healing as well. Wound healing upon extraction of uninfected erupted teeth was not disturbed by infections. Hence, prescribing antibiotics is the physician's prerogative, and usually covering it during the presence of any kind of extraction, covering the well with antibiotics is the dictum, of course, on the baseline of reasonably good glycemic control. The link between diabetes and oral cancer, you've had multiple reviews which have shown this link among people with periodontitis suffering from diabetes. There's a 2.5 times higher greater risk for oral squamous cell carcinoma, something that we need to keep in mind. What about the link with diabetes complications? So diabetic neuropathy, as mentioned earlier, can lead to even burning mouth syndrome, taste impairment, hyposalivation, and xerostomia. Those who have retinopathy, there's actually a positive correlation with the worsening HbA1c and retinal and gingival hemorrhage in presence of retinopathy as well. Those who have nephropathy will have higher chances of periodontitis and related to poor glycemic control and poor immunity in presence of nephropathy. The oral microbiome composition varies at different sites in the mouth. Microbiome in the dental plaque and pockets between the gums and teeth varies with levels of hyperglycemia, and that's the link, and hence the need, which is bidirectional, that you want to have your patients maintaining good glycemic control to have to prevent the nature of microbiome, which can be more pertinent to immune inflammatory response. The composition and quantity may actually predict normoglycemia, pre-diabetes, and hyperglycemia or obesity. What about the treatment? So periodontal treatment will actually land up improving glycemic status. Non-surgical periodontal treatment, NSPT, or deep cleaning, which will remove the deposits and tar, can actually reduce glycemia. The NSPT associated with reduced inflammatory biomarkers has been noted, and hence the inflammation comes down. In fact, you've seen reductions in A1C to the tune of 0.3 to 0.4% purely by even non-surgical treatments. So what's the need? My larger message through this conversation is getting again to be aware, both from the physician's aspect as well as the dental physician's aspect, that there is a strong bidirectional link. There is a huge need for interprofessional collaboration, and hence glad that this kind of an initiative between the physicians and diabetologist and dental or oral health specialists through Diabetes India. There is a need for oral healthcare and awareness, screening for diabetes in the dental office, and we've said that very often having a glucose meter in every dental clinic is extremely important, including good oral health and diabetes management, something that we physicians tend to ignore. In our files and in our communication to the patients, we talk about symptoms of hypoglycemia, treatment of hypoglycemia, need for monitoring. And when we have our routine annual checkups, it's important that we also include the need for oral health examination as well. Interprofessional diabetes management, guidelines for interprofessional diabetes management are also extremely important. And that thought is what was behind the joint statement from the Indian Society of Periodontology and the RSSDI, which came out with this position statement, which was published in both the Journal of Indian Society of Periodontology and our journal, the IJDDC, where the group came along, and I had the privilege to working with this involved group to come out with the joint statement on this bidirectional link. The key objectives there was to provide good clinical practice guidelines for management of periodontal disease, to enable a collaboration between periodontists, dentists, and diabetologist physicians in daily clinical practice, and to offer more improvised, effective, and optimal care. This is something which came out 2.5 years back. It's still early days. I feel it's made some awareness and inroads, but a lot more needs to be done for both the specialist categories to be involved a little more. The must-do aspect, I would say, in diabetes and oral health, regular checking of blood sugars for any oral work is necessary. Let's not ignore it, and that's what I would remind my dental friend community there. And regular oral care and dental visits are also equally necessary, something that the physicians, diabetos need to speak to their patients about the need for the same, just as we would do about screening for retina and neuropathy. The oral care and oral hygiene and a visit to the oral surgeon is extremely important. Dentists and physicians should collaborate for the medical management. A glucose meter at a dental clinic would be extremely helpful. Dentists should or could regularly measure the depth of the space between the tooth and the soft tissue to pick up early signs of infections and pockets in periodontitis. Physicians should ask for pointed questions pertaining to oral health and examine for at least loose teeth. We would agree that not many of us understand much about the dental anatomy and the structures, but basic, simple questionnaires and examination should at least make us ask that and direct our patients to see the dental surgeon at the earliest. So the impact of this diabetes, periodontal disease, and the role of physician and the dentist coordination, counseling by a physician on better oral health. Both disease increase the epidemiological and financial burden and worsening of the glycemic control, including loss of teeth. Due attention to be paid to patients of diabetes complaining of taste alteration. So this is, again, part of the clinical experience I wanted to share. Very often we tend to shun away some of these symptoms as non-specific. In a physician's clinic, busy practice, number of patients, one that typically in India the physicians would see. Somebody's complaining of dryness of mouth, some taste change, dry mouth, and we would say, oh, this is nothing, this happens in diabetes. So let's start focusing and having an index of suspicion there. The correspondence between physician and dentist, every time in doubt, talk to your dentist friend that, my patients are complaining of this. Could this be a sign of something different? And you'll always figure out something important and pick up things much earlier. So an effective synergy between the physician, dentist, and patients to maintain periodontal stability and glycemic control, which is going to be bidirectional. So the take-home message is that this bidirectional relation between poor oral health and its impact on hyperglycemia and vice versa is now well established, as both are chronic inflammatory conditions associated with bacteremia and immune response. Regular checking of blood sugars for any oral work is absolutely necessary, and regular oral care and dental visits are also necessary. A transdisciplinary team should be functioning in sync for improved patient education and management of both periodontal disease and diabetes. Brush your teeth thoroughly twice a day at least. So with that, let me thank all of you for having me here, and I hand it back to the chairpersons.
Thank you, Dr. Manoj, for a comprehensive covering of the topic. Can we take any questions now, or is it after the end of this session?
After this
let's take it now.
Yeah?
Because I'll be rushing and I have a flight to catch, so I'll be rushing. I'm sorry. So any questions, I'll be happy to answer. And I'm not sure whether Bansi is able to join in because he's caught up in a function, but Dr. Sangeeta can speak to him and figure out. But I'm happy to take any questions if there are.
Right. Are there any questions in chat box? Do we see?
I think there are no questions in the chat box.
Well, great. I think then the message is clear. And sorry, was there a question?
No, it's not a question. Actually, just an addition. Whatever you have said, you very rightly said that undiagnosed cases which comes to our clinics with diabetes mellitus, undiagnosed cases or non-diagnosed cases usually turns up in our clinic with gingivitis or bleeding gums. And many a times we have seen that we send them for any blood workup and they turn out to be a patient of diabetes, of increased blood sugar. So, a very nice presentation, Doctor.
I honestly feel that at least that the dental community has been a little more aware, and physicians have largely ignored this and have not prioritized the screening for the same or even being aware. So I often say that at least let's understand the basic aspects and stop ignoring when the patient is at least telling you some of those subtle symptoms. If we don't understand, at least insist on an oral checkup and a visit to the dentist office to have things picked up at the earliest.
Dr.
One
Manoj,
more question,
one question.
one more question, just a
Okay.
question.
Yeah.
Regarding that regular checkup of blood sugar, when in your must-do slide, that regular checking of blood sugar, is there any age-related fact? Should we look for some age? After some age, it should be compulsory for all the patients.
Well, I think in today's time, we would say screening for every individual above the age of 30 who hasn't had it screened. And more so. So when you come across, let me give an example. Somebody visits, even at the age of 35, visits a dermatologist because of genitourinary infection or fungal infection on the private parts. The dermat is immediately going to ask for getting the sugars tested. So if you come across an individual who doesn't have any low immunity otherwise and has come with a really bad periodontal disease, you should probably think that this guy is low on immunity and having screened at least for diabetes amongst other things. So that index of suspicion, when you see something which is very florid, ask for the sugars to be tested irrespective of the age.
One question, Dr. Manoj. When we say there is a bit of a gap between the pushing the agenda of oral health amongst the diabetic patients from the physician side, how, in your opinion, do you think can we mobilize this? Because guidelines, everything is fine. They are in the documentation. How to take it to the clinical scenario aggressively is what my question hints at.
Well, I think all these aspects of awareness and education is what it's doing. It's always a phase. If you look at few years back, was every individual with diabetes getting screened for their retina?
Right.
Today, we know that that's become part of many standard practice in diabetes OPDs today, where this would be spoken about.
Right.
What's also changed the scenario is the point of care devices for screening. So I've also said that if there are simple screening tools, what happens is the inertia. I will tell the patient to go and see a dentist who may not go. The next visit 3 months later, when the patient comes to us, we'll ask, well, no, I felt better. You told me, but I felt better, so I never went. So there's huge inertia. So any aspect which actually allows things to happen at the same place.
That's true. That's true.
Will always change scenario.
This is something little missing as POC in the dental scenario, actually. I mean, there's a way to go forward. Let's see how it mobilizes.
How
we'll have a
that can
chat
be done,
with Dr.
right.
Purnima also on this, probably. Yeah, Dr. Balaji.
Yeah, Dr. Manoj, thank you. That was a nice presentation. And regarding the diagnostic criteria, as Dr. Purnima also here is saying that dentistry is considered a surgical specialty, it is below standard of care to do anything on subject without documented glycemic index. Just to make things very easier and simpler in diagnosing, all of us do keep a glucometer in the clinic and all these things. The simplest way to do this, actually, it was a study also which was carried out from the gingival bleeding itself, when the blood can be taken and it can be used for diagnosing the bleeding. A study was carried out way back in 2013. It's been published. It shows that the gingival clavicular blood value and the peripheral finger prick value, there is not much of a difference, both in diabetics as well as in non-diabetics. So it's a very simple thing. When we are doing the examination and see the bleeding gums, instead of pricking the finger, just take the gingival clavicular blood, which can be used as a diagnostic criteria. So it becomes very simple. I think it should be done more often than not in the clinic to check for diabetes.
That's interesting, Balaji. I wasn't aware that we could use the gingival blood for doing that, and there is no real difference. I'm not sure.
I will share you the article right away, because it was done by my postgraduate only, so I am aware of these things.
Interesting, very interesting. But yeah, I think if that is much validated even by the glucose meter companies who give a specific site for where which we can use, if we can have further validation, at least in your office. But honestly, even if that's not there, a finger prick is not really too difficult, which is far more validated. But point taken that whatever makes us assess easily and screen should be great. Thanks
You
for,
have
thanks
the
for
link in the
that.
chat box, Dr.
Yes, I
Manoj.
see
The
that.
link is there. Yeah.
I see that. Thank you so much.
Yes.
Any other questions from the house?
I just want to say that an excellent presentation, and I hope that it would be further disseminated in your clinical settings. So very well done, Dr. Manoj.
Thank you. Thank you. And let's enjoy the rest of the sessions. Thank you. Thank you for having me here.
Thank you, Dr. Manoj.
Yeah. Now,
Dr. Sangeeta, you're not audible.
Cannot hear you, Sangeeta. Unmute yourself.
Our second lecture. Dr. Anandita Banerjee. I feel highly elated to introduce Professor Dr. Anandita Banerjee, who is our second speaker for the day. She passed her BDS with gold medal in conservative dentistry and endodontics, MDS in 2000 in periodontics from Dr. R. Ahmed Dental College and Hospital, Kolkata. Recipient of Dr. Y.P. Guglani Award for the first prize in basic research and Dr. T.N. Chawla Award for best dissertation from Indian Society of Periodontology, is professor and head Department of Periodontology and Implantology. She's a postgraduate teacher and guide with numerous publications in national journals. She's involved in weekend practice limited to periodontics at Kolkata. She is also the advisor in Diabetes India Oral Health Group. So over to you, ma'am.
Thank you, Dr. Sumedha, for the introduction. Am I audible?
Yes, ma'am, you're very much audible.
Thank you for the introduction. Let me start by sharing the screen. Good evening, respected chief guest, Dr. Purnima Kumar, ma'am. Chairpersons for the evening, Professor Colonel Dr. Srihari A.K. and Professor Dr. Saurabh Srivastava. Diabetes India office bearers, Dr. Banshi Sabu, Dr. Amit Gupta, Dr. Manoj Chawla. Diabetes India Oral Health Chair, Dr. Sangeeta Dheer, Co-Chair, Dr. Sumita Bansal. Respected Dr. Vandana ma'am and dear delegates. It is indeed difficult to be the penultimate speaker because much of what I intend to say has already been covered. So kindly allow me to rush through the slides that are mere repetitions. Now, this is the Department of Periodontology, Buddha Institute of Dental Sciences, the undergraduate section of the Department of Periodontology, Buddha Institute of Dental Sciences and Hospital, Patna. I have been a faculty at this institute ever since I completed my post-graduation way back in the year 2000. We are privileged to have a huge number of patients reporting to the hospital on a daily basis. And this is how the department looks like, typically on a working day morning. And my weekends are restricted to practice at Kolkata at our own clinic. Now, so I represent the two states of Bihar and West Bengal, which are overpopulated, if I'm allowed to say so, and they enjoy the hinterlands of the neighboring states and the adjacent countries, the neighboring adjacent countries too. So all these factors have helped me to have an insight into the clinical aspects of patients from varied socioeconomic strata. As you know, and would agree with me, that in India, there is an obvious difference in the socioeconomic profile of patients reporting to a hospital and those coming to a private clinical practice. So it is my privilege that I have been in touch with so many different varieties of patients for such a long time. And what I've observed is that the diabetic patient in dental clinic can be classified into three groups. Patients who are unaware of their diabetic status, and unfortunately, we dentists are the first ones to give them this bad news, to reveal them to their diabetic status. Patients who are aware and are controlling their diabetic status properly, and patients who are aware, but due to whatever reasons, they have not been able to control their diabetic status. Now, what is the common link between all these three types of patients? Almost all of them are unaware about oral health issues in diabetes. Patients who are coming to the hospital, 99 to 100% of them are unaware about oral health issues in diabetes. Patients who are coming to clinic, I would say about 5 to 10% of them, they have a vague idea that there may be oral health issues, but none of them have a clear picture of what is wrong or what may be wrong in their oral health status. Now, oral health issues in patients with diabetes mellitus may be due to various reasons. We have discussed this so many times since yesterday that I would like to skip this slide. Now, the oral manifestations of diabetes mellitus, this also we have discussed that they can be in the hard tissues and the soft tissues, combined in the both hard and soft tissues. For example, the periodontal diseases. Now, as far as the oral symptoms with which the patients of diabetes mellitus present to a dental clinic, the commonest of them being the periodontal signs, the periodontal symptoms of swollen gums, bleeding gums, sometimes mobile teeth. Other than that, dry mouth, which can lead to dental caries, burning mouth syndrome. Patients often complain of altered taste sensation, as Dr. Manoj was talking about. Patients complain of sticky mouth, which may be due to xerostomia or due to periodontal disease or due to both combined. And almost all of them have a complaint of bad breath. Now, the oral signs of type 2 diabetes mellitus, of course, the vast majority of patients, we can see periodontal diseases in them with multiple acute periodontal abscesses. Suppuration from some of the periodontal pockets are a common occurrence. Candida-related oral lesions like angular cheilitis, median rhomboid glossitis, erythematous stomatitis, all these are also very common. Tongue abnormalities are not that common, but we have seen patients with fissured tongue, bald tongue, geographic tongue, that is benign migratory glossitis. All these are evident in patients with diabetes mellitus. Halitosis with ketone breath, dry socket, as well as oral lichen planus. So let's just have a look at the clinical features, photographs of the clinical features. Periodontal abscesses, multiple periodontal abscesses are said to be the hallmark of the symptom of diabetes mellitus, or the sign of diabetes mellitus. Angular cheilitis, yesterday, this was also discussed by Dr. Domenica. She pointed out that this may be due to a side effect of metformin, which leads to vitamin B12 deficiency, which can cause angular cheilitis. Median rhomboid glossitis, erythematous stomatitis. This is in an edentulous patients, can be seen in dentulous patients also. Fissure tongue, bald tongue, geographic tongue, dry socket. Now, dry socket, previously this used to be a common scenario, but nowadays, as before all dental procedures, we check the patient for their diabetic profile. And if we find that the patient is suffering from diabetes, whether controlled or uncontrolled, prophylactic antibiotics are prescribed routinely. So alveolar osteitis or dry socket is not that much of a common occurrence now, but previously this was quite common. Now, oral lichen planus, this is attributed to a state of chronic immunosuppression in diabetic patients, and patients who report with oral lichen planus, especially erosive lichen planus, in diabetic patients who report with that, it is very difficult to satisfy them, because there is no long-term treatment. Like whatever we do, patient after discontinuation of the treatment, patients somehow they revert back to their maybe not previous status, but all the symptoms are not relieved. So it is very difficult to, once these patients come, it is very difficult to satisfy them completely. Now, the oral complications of diabetes mellitus manifest more severely and rapidly in uncontrolled type 1 diabetics compared to uncontrolled type 2 diabetics. But regardless of the type of diabetes mellitus, it is the hyperglycemia, not the diagnosis of diabetes mellitus per se, that leads to all these oral signs and symptoms that we have discussed. And more importantly, the oral health related decreased quality of life. This is very, very important as far as diabetes patients are concerned. As we have heard multiple times since yesterday, that periodontitis was declared to be the 6th complication of diabetes mellitus way back in 1993, and we should take up this responsibility, and we should acknowledge that it is our fault that in spite of this long 30 years, we have not been able to propagate this message to the masses, so that a patient today walks into a hospital or to a private dental clinic with the demand that, doctor, I have been diagnosed as a diabetic person. Please check whether I have any diabetes related oral complications. It is our fault, it is our drawback that patients do not do so even today after 30 years. Now, the signs and symptoms of gingivitis, which is a reversible form of gum disease, and periodontitis, which is the irreversible form of gum disease, have been discussed time and again. And the signs and symptoms of periodontal diseases, I'm not going into that. What we should remember is the most prevalent chronic diseases share the same common risk factors, irrespective of whether causal links are there or merely associations exist. Why? Because type 2 diabetes mellitus and oral diseases like gingivitis and periodontitis are both very prevalent. Both of them are chronic conditions, and both of them share common risk factors. Another factor which I would like to stress upon is that oral diseases do not have signs and symptoms that are pathognomonic for diabetes mellitus and vice versa. Although diabetes is often associated with increased gingival inflammation in response to bacterial plaque. This response may be related to the level of glycemic control, with subjects with well-controlled diabetes having a similar degree of gingivitis as non-diabetic individuals. That is why we cannot say that it is pathognomonic. And poorly controlled diabetic subjects having significantly increased inflammation. The significantly increased inflammation may be encountered in patients without diabetes. So there is nothing pathognomonic in that, but obviously these factors do exist. So if we can see that bleeding on probing, if we probe the gingival sulcus or the periodontal pocket of a person, there may be various levels of bleeding. So a patient with diabetes, uncontrolled diabetes, most of the times they present with the photograph that we see on the extreme right-hand side of the screen. But the same patients may present with anything from the extreme left to the extreme right. Similarly, patients who are non-diabetic can come up with anything from the extreme left to the extreme right of the photographs. So in spite of it being not pathognomonic, increased gingival inflammation may be seen in diabetic subjects, even though plaque levels are similar to non-diabetic controls. So increased gingival inflammation is a problem, in spite of it not being pathognomonic, but it is present in the vast majority of patients. So in 1996, Papapenau did a thorough analysis of the literature and demonstrated that the majority of studies show a more severe periodontal condition in adult patients with diabetics than in non-diabetic adults. And diabetes may influence not only the prevalence and severity of periodontitis, but also the progression of the disease. So prevalence, severity, and thirdly, progression. It has been shown that type 2 diabetes mellitus significantly increases the rate of alveolar bone loss progression over a 2-year period when compared to a non-diabetic subject. And the risk for progressive bone loss was shown to be 4.2 times greater in diabetic subjects in a particular study, with the greatest increase in risk occurring in patients under the age of 34 years. Now, the relationship between metabolic control of diabetes and periodontal disease is still not very clear. Some diabetic patients with poor glycemic control develop extensive periodontal destruction, while others do not. That is why I'm stressing upon the fact that it is not pathognomonic. Conversely, many patients with well-controlled diabetes have excellent periodontal health, but others do develop periodontitis. Poor glycemic control is clearly associated with increased risk for complications. But again, not all patients with poorly controlled diabetes develop these complications. While there is no unequivocal dose-response relationship between glycemic control and periodontitis, many studies support the clinical observation that patients with poorly controlled diabetes of long duration tend to develop more advanced periodontal destruction than diabetic patients with good metabolic control. So duration of diabetes is a very important factor. Thus, metabolic control of diabetes may be an important variable in the onset and progression of periodontal disease. Now, as we all know that periodontal diseases are very common, so other risk factors of periodontitis like poor oral hygiene, smoking, stress, and socioeconomic conditions should also be considered when we try to establish a causal relationship between these two diseases. Now, let's go on to the next point, that is, it has been established beyond any doubt, we all are aware of this, that periodontitis is a low-grade infection capable of developing a low-grade systemic inflammation with an ability to influence the general systemic health. Now, is this inflammation quantifiable? Can we quantify how much inflammation is there? This is for our physician friends. All periodontists are aware of this, that the inner wall of the periodontal pocket is inflamed and ulcerated, and it can be measured with the help of a periodontal probe. And when we are probing the gingival sulcus or the periodontal pocket, if the tissues are inflamed, there will be bleeding. We call this bleeding on probing. And if we add up all the lengths of the sulcus or the pocket that bleed on probing, we will get the periodontal inflamed surface area. Now, this has been used as a tool to accurately assess the amount of periodontal inflamed tissue in a subject with periodontitis. And it has been established that PISA quantifies the inflammatory burden posed by periodontal diseases on the systemic variables of the patient. Now, it has been reported by Luz that a significant cumulative surface area of all periodontal lesions in patients with severe periodontitis may range from 15 to 20 square centimeter, as Dr. Anupam Dekar presented that photo yesterday, which has been haunting generations of periodontists. So this is not a small number. This is not a small area. 15 to 20 square centimeter is the cumulative surface area if the person is suffering from severe periodontitis. So definitely this will have an effect on the systemic status of the patient. So PISA represents an active periodontal inflammation and a consistent rise in the PISA scores. In the PISA scores with different stages of periodontal disease progression has been observed. So according to the latest classification, the different stages also show a consistent rise in PISA scores. Now, why am I talking of all this? Because there is a dose-response relationship between A1C levels and PISA in type 2 diabetics. the higher the PISA of type 2 diabetics, the higher their A1C levels. An increase in PISA with 333 square millimeter is associated with an increase of A1C of 1 percentage point. So if periodontal diseases can be controlled, if the patient comes back for maintenance therapy, which is the hallmark of any periodontal treatment, then we can assure the patient that their HbA1c can also be controlled to a certain extent. And as it has been outlined by Dr. Chawla, I'm not going into all that. With proper periodontal treatment, there can be a 0.3 to 0.4% decrease in A1C level. So if we can make our patients understand this, if we harp upon this point, that an increase in PISA will lead to increase in A1C levels, and with periodontal treatment, A1C levels can get reduced, then of course we will have more, patients, as Dr. Chawla said, that patients feel that, okay, my problem has been resolved. I do not need to go to the dentist anymore. So to prevent that, if we can harp on this fact, I think that will help this, whatever we are trying to do with all this. Now, the RSSDI recommendations we have discussed time and again, so I'm not going into all these details anymore. This is the American Academy for Oral and Systemic Health. They have given similar recommendations. And as Dr. Balaji pointed out, that gingival crevicular blood obtained during periodontal probing may be an excellent source of blood for glucometric analysis, provided, as Dr. Purnima Kumar told us, that salivary contamination is a problem, if we can solve that issue. So this is more important for dentists, because you see, we have patients who come to us with their A1C levels. But when I'm going to perform a periodontal procedure or any dental procedure for that matter, I want to know at this point of time, what is the blood sugar of my patient? So for that, a glucometer is kept both at my clinic and at the hospital in the department. All our PD students are using that glucometer before performing any periodontal surgery. But the problem is that, when a patient comes to a dental clinic, there is always a level of apprehension. And to add upon it an added finger prick, that adds to that apprehension. So we can very easily do away with that apprehension if we use this blood, which anyhow is coming out, is oozing out because of periodontal probing. And this is painless and more comfortable, definitely more comfortable. And that apprehension factor we can do away with it. And this is instant GSI diagnosis. So this is an important thing that we should all try to incorporate. So I've come to the end of my presentation today. Research to promote the understanding of mechanisms underlying reciprocal links between various aspects of oral health and diabetes mellitus is rapidly emerging, as all the presentations have shown us. However, the evidence that we have currently, that is sufficient to act. And I'm so happy that Diabetes India and ISP both are trying to do the same. Both have joined hands to do the same. And with this, a big thank you to Diabetes India OH group for inviting me for this presentation. And I hand over to the chairpersons. Thank you all. Good night.
Thank you, Dr. Nandita, for the wonderful presentation. Over to the chairpersons.
Thank you, madam, for the very good presentation depicting about all the aspects of dental health, which we physicians usually ignore. And we don't look about all these changes, and we are just concerned about the blood sugar values, as has been discussed since the start of the presentation. I think there are no questions in the chat box currently. Any questions from the audience?
Doesn't seem so.
There's been a nice presentation, Dr. Anandita. I will just add upon something like about this periodontal inflammatory surface area that you have covered. That we say we quantify it in 15 to 20 centimeters square. So when that is the That is the area, no? That right, which is the in a severely affected
in case of, yeah, yes,
severely
sir.
affected. So whenever we used to interact with the physicians, we used to ask them, well, initially, that an area which is almost 15 to 20 centimeters square is almost your forehand, forehand.
Yes, sir.
We used to say, if there is a redness in your forehand, will you not go to the doctor for treatment?
Exactly
This
so.
size.
Exactly. Yeah.
So if you extrapolate that 15 to 20 centimeters, in fact, for patient education also, we can use that. We can extrapolate that and tell it to them for their education. In
Obviously,
severely
sir.
affected cases.
Obviously.
This is just a addendum to your presentation. That's.
Hello, Dr. Anandita. It's a very good presentation of the.
Thank you, ma'am.
Very good presentation, in fact, of the reality, as I told you, I have written in the chat. Actually, as a clinician, I would like to ask you, what are the most common signs we have come across during our tenure? See, actually, I have seen multiple abscess being the first diagnostic factor in the clinical practice. Do you agree with that? Because most of the
Definitely,
diabetics,
ma'am.
yeah, because there's a list of oral manifestations, but from the periodontal point of view, what we get to have is first and the foremost is multiple periodontal abscesses.
Multiple periodontal abscesses,
yeah,
and gingival bleeding on probing.
Yeah, that's what you have mentioned. And secondly, I would like to say the breath, acetone breath, is very diagnostic for especially with the mask. I think the organoleptics are hampered, but otherwise, I would say this is what would take us to the diagnosis for diabetes unfound by the patient. Patient is not aware, but we try to suspect. See, these two are the major diagnostic features which I have found during my clinical practice, or most diagnostic. Rest of it, all those, of course, with dry mouth, caries, and etc., being tagged along, they all have been a part of it for the listing. Because as early as 1930, Hirschfeld gave the oral manifestations of diabetes. None of our, as an ancestor for the presentation of diabetes in periodontics. But it took Harold Lowe to present the sixth complication of diabetes in 1993. See, there's a huge gap. So we stuck, it was being mentioned as a part of diabetes in 1930 itself in the Journal of Periodontology. But of course, we took a long time. Long time, of course. But it is a part of it. It's a part of us. Whenever there is a periodontitis and diabetes co-occurrence, we are concerned. And what the physician has to do is that co-occurrence has to be sorted out. Opening up our eyes have been already done, because we read a lot of diabetes, a lot of things about diabetes, but that doesn't happen with the physician's part of it for the periodontium part. I hope you agree with that, Anandita. See, most of us
100%, ma'am, 100%. But what I would like to stress upon is how much have we progressed since 1993? How much have we progressed?
That's what it is.
What is your views, ma'am?
Yeah, consensus on clinical expectations are zero. It has remained the same.
That's what.
It has remained the same.
It has
because
remained
the rest of it is growing for a different reason. But it is not with the. But that is what is growing with the periodontists, but not with the. I would like to say, just very humbly say that the physicians have to open up now for this condition. If the glycemic.
I agree with you 100%.
Yeah. Because even this HbA1c, only for the 3 months, it has the early effect, which the periodontal therapy can have its effect. But the longer terms, it is not proved properly. Like there is not been very helpful, because long-term studies on this. Only for the 3 months, it has been said to be very helpful, the periodontal therapy. So all these facts probably have to be revealed, or the diabetic association have to get into looking into all this, because oral health, especially from the periodontal point of view, can be very helpful for the patient if they coexist. And good screening is always important. As been told from yesterday, a good oral health screening is very important. And a simple radiographic examination, if it is sent to a periodontist, also is very useful. And we can play safe with the diagnosis to help the diabetic patient in a better way. Okay, with that note, I just wanted to say this, because Anandita, you spoke of the most of the realistic aspects of diabetes and non-diabetic conditions. And that was a very good presentation from your side. Thank you for that.
Thank you so much, ma'am. Thank you so much.
Sangeeta ji, I just want to make one comment.
Yeah, please,
Saurabh
sir.
is with the permission of Saurabh.
Certainly,
As
sir.
most of you are experts.
It's my pleasure.
You all of them are very expert in the field of the periodontology. But as we know, when we were talking the diabetes and oral health, something we should come out. And with this presentation, I was thinking that if we can come out with some very simple, some sort of information which can be an education material, which can be put in the diabetologist or a doctor's clinic regarding the diabetes and oral health, for there some common problems, and when they should reach out to the the doctors or a dentist or for oral health, because commonly, as Saurabh will also agree with me, being he's a senior professor and doing practice of diabetes since years, but how often they normally send the patients is really difficult. So I think some simple education material which can be created by Diabetes India and Oral Health Group, which can be kept in the clinic of a doctor, and that information which is also for the patients primarily. And this information we can circulate to all the physicians. And now we have this La Renown company, they had come out with a very special toothpaste also, and they are having also the anti-diabetic medicine, and they agreed to be the part of this organization, and they would like to support us. So I was thinking that if we can do it, will be very helpful.
Sure.
I'm sorry again that today my connection is poor.
Not at all,
so
not at all.
I'm not. So please take care of it.
So we'll be seeing you in the panel discussion, Dr. Bansi.
Hello.
Yeah. Okay. Anyway. Okay. So now we come to the end of this session, and we'll be soon starting the panel discussion. Before that, we would like to just quickly give a round of revision for the patient education pamphlet, because DI officer advised us to do so. Kushal, can we have that on the screen, please? So all the new delegates and the faculty who have joined, yesterday we had released this Diabetes India Oral Health Group education pamphlet. Next slide, please. So basically, what are the highlights? It's like first of time it's getting released in India. Nothing has been released so far on this subject. It has been created by Diabetes India, and the important highlights, that's like visually appealing to the patient with the colorful design and graphics, which is going to be an educational tool both for the dental and the diabetology practices. May we have the a brief preview of the pamphlet as well, Kushal? Next slide. So that's the way it looks. So once it comes into print circulation, that's the time it will be reaching your respective clinical practices as well. Next slide, please.
This Sangeeta you sent me also, I think.
Yeah, that's a oral health manual pamphlet, na sir? So we are first releasing it here only. So after this, it rolls out to the public section.
Yeah, we will release it in Diabetes India annual conference also.
Yeah, sure, sir, sure.
So the physical copy they can take. And
absolutely,
then with the La Renown, we will send it across the country.
Absolutely, sir. Right, sir. So can we start? Yeah, sir, please.
1 minute, Dr. Bhat.
We can give it to industry also to make it more. Right?
Right.
Dr. Sangeeta,
yes, sir.
Since it is a patient education pamphlet as well, I would suggest that printing it in the local language also would be beneficial.
We have that in mind. So first time we had just got it in English. So some regional language we will do
English
that.
and Hindi primarily we are doing it. Then we are trying to get it in 15 national languages.
Right.
So that is there on the agenda basically. So we will now switch on to the last segment of the scientific session. That's a panel discussion for which we'll be just inviting the whole team. So to begin with, I would like to introduce the moderator for the panel discussion. Can we have the bio sketch, please? So the moderator for the panel discussion is Professor Dr. Abhay Kolte. He is Dean, Professor and Head of the Department of Periodontology and Implantology, Ranjit Deshmukh Dental College and Research Center, Nagpur. Sir is the immediate past president of Indian Society of Periodontology. He has a teaching experience of more than 20 years. He is a recognized postgraduate and PhD guide at the Maharashtra University of Health Sciences, Nasik. He is a member board studies of MUHS, Nasik. He is a keynote speaker at various national conferences and has 150 and above publications in international and national journals. He is a live member of Indian Dental Association, Indian Society of Periodontology and ISOI. So over to you, sir, for this panel discussion. Before we initiate, we'll be introducing the panelists as well. So may I invite Dr. Sumedha Bansal to introduce the first panelist, Dr. Bansi Sabu, please. Can we have a slide?
Yes.
I'm very much here. Did not to talk, everyone knows me.
So please, we will want to hear your introduction, please.
I feel highly honored to introduce Dr. Bansi Sabu, who is President Diabetes in Asia Group Study Group, Secretary Diabetes India and Indian Academy of Diabetes, past President RSSDI and AIAARO, founder of DTech Diabetes Care NGO and India Sweet Registry, Hub Leader Eco India Ahmedabad, Managing Editor Sadiko's International Textbook of Diabetes and Metabolic Syndrome, Clinical Research and Reviews. He is the advisory board member, many journals including JAPI, Journal of Diabetology and JOMR. Honored with fellowship by American College of Endocrinology USA, American College of Physicians USA, International College of Nutrition, FICN, Royal College of Physicians, Glasgow, Edinburgh, and London, MNAMNS, Diabetology, expert of RSSDI guidelines for management of diabetes, ATTD CGM guidelines, and ISPAD guidelines for pediatric diabetes. He has numerous publications, more than 150, in index journals and have contributed chapters in various textbooks and monograms. He has completed many public awareness projects under Diabetes Care India, such as RSSDI, Defeat Diabetes Campaign, KADAM, Knowledge-Based Diabetes Awareness Movement, IDEA, Intensive Diabetes Education and Awareness to Stop Heart Attack, Multiple Diabetes Clinic along with AMC with support of WDF, and Improved Standard of Care for Type 1 Diabetes in Gujarat, that also supported by WDF. So, welcome, Dr. Bansi.
Thank you, Sumedha, for the kind introduction. May we have the next panelist, Dr. Vandana KL's biosketch, please. So what better would be an honor for a student like me to introduce my mentor and my guide, Professor Dr. Vandana KL, ma'am. She is the ex-head of the Department of Periodontology, College of Dental Sciences, Davangere, Karnataka. She completed her panel BDS from the prestigious Government Dental College, Bangalore, and did her post-graduation in periodontics from Bapuji Dental College and Hospital, Davangere. She has had an enriching experience of 35 years. She has been the examiner postgraduate guide with various publications in high citation index journals of H index 20 and I-10 index 37. She has served as chairperson for MDS Periodontics Syllabus Formation, board member of undergrad, postgrad, and PhD studies at Rajiv Gandhi University of Health Sciences, and is a postgraduate PhD guide. She has undertaken various corporate research projects of Colgate-Palmolive, US. Her area of interest involves periodontal health and disease in dental fluorosis under scanning electron microscopy and autologous stem cell research in periodontal regeneration. She is also an advisor for our Diabetes India Oral Health Group. Welcome, ma'am, for the panel discussion.
Thank you, Sangeeta.
Now we move on to the last introduction for the last panel discussion panelist. Can we have Dr. Anupam Dekha to please introduce the last panelist, please?
I'm happy and honored to introduce our panelist, Professor Dr. J. Selvakumar. Professor J. Selvakumar is MDS in periodontology, and he is the professor and head of Department of Periodontology and Implantology of Adi Parasakti Dental College and Hospital, Chennai. We welcome you, sir, to the panel discussion.
Thank you, Anupam, for the introduction. Over to Dr. Abhay Kolte, sir. The podium is yours, sir.
So thank you all for the kind introductions of all the esteemed panelists. And first of all, before beginning with the panel discussion, I would take this opportunity to congratulate Diabetes India and also appreciate the efforts of Diabetes India Oral Health Group, who have been active in this novel initiative. In fact, it is much needed initiative, and I would credit Sangeeta with all the homework or lay work which she has been doing over the past so many years. I have seen her working in Indian Society of Periodontology, and she was the person who had taken initiative as far as having a coordinated symposium with RSSDI and Indian Society of Periodontology head office. Now, what we have seen over the past 2 days, that is yesterday and today, we have seen two conditions, diabetes mellitus and periodontitis. And both of these conditions are really dangerous for the entire mankind. And if you go on to see the commonalities of both of these conditions, we see a lot of commonalities, be it the etiologic factors, be it the risk factors, be it the pathologies, and be it the epidemiologies as well. And if we go on to discuss about the epidemiologies of both the conditions, India, in fact, can be labeled as capitals for both of these conditions, because seeing the such a large population being affected with both of these conditions, we healthcare workers, not only the dental surgeons, not only the periodontists, not only the diabetologists, not only the medical practitioners, but then the entire healthcare industry, entire healthcare professionals need to be quite serious about this relationship. And since both of them have been known to affect the other condition, it becomes all the more important to discuss the modalities in which we can manage both of these conditions. And if there is a possibility of having a coordinated efforts as far as management of these conditions, then there would be nothing like it, because it will not only be beneficial for the patients, but then it will also be beneficial for the clinicians, because both of these conditions, if they are managed jointly, then definitely the burden as far as the medicine burden, as far as the periodontal severity burden on the tissues would be reduced to a great extent. Now, I would come to the panelist with a few queries, which we have a few queries. I would be sharing the screen now. Now, the first query which I have to the panelist is, what is the current consensus regarding the relationship between diabetes mellitus and periodontitis? First, I would want to go over to Vandana madam with regards to this.
Hello, everyone. Good evening. And thanks a lot to Sangeeta for introducing me onto this panel. And getting into the panelists now. If this question has to be asked, Dr. Abhay, I would say all the consensus regarding this relationship is being established not by the Indians. Most of the research is all done from the Europe or from the East. Unfortunately, that is the present scenario that we have. What I would like to say here is, wish diabetes being so prevalent and predominantly present in the present situation, the more and more of the work should be considered from the Indian scene. a lot of institutions and a lot of research minds hovering around, and that should be the first. I would always feel, I have felt this because we as Indians, we have a lot of research mind, but unfortunately, because of the lack of funding and lack of the facility, these two F's stop us from getting into larger working scenarios. I hope you agree with that, Abhay.
Yes,
So
yes,
nonetheless,
totally agree with you, madam.
yeah.
But then, if you go on to see, I would pose this question to the other panelist from here, Dr.
No,
Selva.
I just want to say two lines for this.
Yes, ma'am. Yes.
The consensus from the clinical scene has nothing changed, but the relationship that has developed over the years, from the 2000, I would say, the bidirectional relationships which has been happening, we are trying to hear this from most of the speakers. That's pathogenic mechanisms which are trying to be correlated between the two disastrous conditions in its own way. Because periodontitis is no less than diabetes, according to me as a periodontist, I would like to say here. Because one who suffers knows the problem. And most often I compare it with diabetes. I say that if you suffer from periodontitis, you can prevent it for the loss, but you can't stop it at one stage of periodontitis stage. Okay, it's a metabolic disorder. Of course, now that we consider periodontium as an organ, even that can be a part of influencing the diabetes. Okay, most of the growth that is happening is from the all that is there for the pathogenic mechanisms and the interrelationships that is happening as etiological factors which are cross-linked, and again the rest of the molecular aspects which are growing, which cannot be the consensus opinion. Again, I'm saying the quite a few biomarkers have been introduced for the diagnosis in the clinic, but we can't translate it to clinical scenario. The problem is they're very expensive. I would like to say these points for this question, Dr. Abhay. The rest of it you can post it on to Dr. Selvakumar.
Yes. Now, what Madam has been mentioning is with regards to the pathomechanism of interlink between the two diseases. But then when we talk about integrated management of these two conditions, I would pose this query to Dr. Selvakumar. So do we have a consensus with regards to management of both of these conditions? And is there really any consensus statement by any of these specialty organizations with regards to the management of these conditions? We do have certain studies, isolated studies. We do have certain of them mentioning that subgingival debridement would lead to a reduced amount of glycemic burden. But then is there any consensus development on this aspect? Dr. Selva.
Thank you, Dr. Abhay. Am I audible?
Yes, very much.
Dr. Abhay, thank you for giving me the opportunity, and Sangeeta madam and all the organizers. When I went through the consensus report from ISP and RSS, DI and EFP and other things, certain doubts I have in my mind. There is no consensus regarding gestational diabetes, how to manage the case of gestational diabetes, and some cases of type 1 diabetes mellitus. And if you are going to do the certain treatment strategies like laser, photobiomodulation, in what will be that they are given the blood sugar level around 200 will be ideal. If it is more than that, you should have to be in maintenance therapy. What should be the maintenance therapy? It was not clearly defined in some of the consensus. And they say prefer the toothpaste with SLS, without free of SLS. But there are many pharma companies promoting that this is the toothpaste for the diabetic patients like that. So there is no demarcation in that. Fourth one, my point is we do lot of implant therapy. They say the 6 to 8 hemoglobin, glycosylated hemoglobin level 6 to 8 will be ideal for placing implant. What about during the maintenance, during the osseointegrated stages of implant, the blood sugar has to be maintained. That was not produced. And moreover, what should be the dietary modifications or dietary recommendations should be there. This is not in any of the consensus. After a periodontal therapy, either it's a regenerative therapy or implant therapy, what should be the dietary restrictions or specific instructions it can be given. For example, in ISP, this thing, it has been given periodontal abscess. It's an emergency procedure, drainage should be done. If the blood sugar of the patient is, glycosylated hemoglobin level is more than 8, what we are going to do? And if it is not, we can't drain it. If it is a hard swelling, what we are going to do? These things were not clear. Maybe in future consensus, if the clear-cut, the specific therapy, sometimes we say severe chronic periodontitis only, we should be bothered. What is the treatment plan for the mild and moderate cases of periodontitis? So if we can have this consensus on various treatment protocols in periodontal treatment, it will be good. They say oxygen therapy, they say photobiomodulation. What are the implications for it? If we come to that, it will be good in future consensus. If we have something for management like this, it will be better. What should be the ideal blood glucose level where you can carry out for different procedures like this?
Dr. Abhay, I just would like to add a point here.
Yes, ma'am.
Integrated treatment aspects for both the diseases.
Yes, ma'am.
Most often we only hit the both the diseases with one of the allopathic drugs, right?
Yeah.
But recent interest of herbal medicine, especially one which I've tried with Guduchi, all of you know, Tinospora cordifolia. This is Sanjeevani for both the diseases. It is anti-diabetic, it is anti-arthritic, it is immunomodulator. You know, there are a lot of literature being discussed in the journals of Ayurveda. And this is translated, if I had opportunity to do that, and it does wonders in the treatment of periodontitis. Okay, I wish if the, because most often what happens, Abhay, most often what happens is, see, the insulin problems with the diabetes is only treated with the respective drugs, but the consequences of diabetes like inflammation, the immune modulation which get disturbed, lot of cytotoxic materials that are produced have not been taken care. I feel, I'm not very sure how that has been managed by the specialists, but if we can introduce herbal medicine along with conventional allopathic medicine, where they don't have a proper, you know, they usually say there is no as such a complication being developed by the herbal medicine. It is a good idea to initiate, is my suggestion to both the periodontists and the physicians.
Okay,
because basically herbal medicine is part of Indian origin, and we are proud to use it back. And turmeric has been introduced, is being widely researched in various other countries other than, of course, we do. The problem with us is we don't get to have a publication done for a lot of reasons. It doesn't come into picture, and it doesn't come into reality, usage of this and suggestions of this. So if this can be initiated, I would say integrated disciplinary approaches for both the diseases, which have got common platform in lot many things, especially immunomodulation. Without your knowledge, it is getting disturbed and distracted and having a lot of disturbing complications. I'm sure with Guduchi, with one drug which has been very potential for treatment of both the conditions. Okay. Yeah, thank you for giving me this.
Madam, for the relevant inputs, Madam and Dr. Selva Kumar. In fact, there are definitely quite a few lacunae with regards to our consensus in the treatment aspect of both the conditions. And as Madam has rightly said, there could be a important role for the herbal medicines as far as management of both of these conditions are concerned. Now, if Dr. Bansi, sir, is available, can I pose a next question to you, sir? Bansi, sir? Dr. Bansi, I think there's some problem with his connection. So can we go ahead with this query to Vandana Madam? Do you envision an integrated approach between the medical and dental health professionals as far as management of both these conditions are concerned? Now, we as periodontists, having seen the perspectives of periodontal surgeons, we definitely would believe and envision an integrated approach. But then what would you suggest as far as management of these conditions are concerned? What is your take?
See, from dental aspect, we are trying to go ahead in the systematic approach for the treatment of periodontitis, of course, and the diabetes. Without the physician's consent, we don't go further at all. We don't touch the patient if they don't give us the consent. But medical side is what is important to us. From the physician side, if we could have a good approach to take care of their condition as well as the periodontitis, of course, but at least referral to a periodontist as bare as minimum as that. If they could do that, finding out from what may be, see, all diabetic patients will not have periodontal manifestations. See, periodontal manifestations are present in only very, and I have no actually the idea how many of the diabetics could have this periodontal manifestation, various aspects of it. But a cursory, one simple examination of the oral cavity and the periodontium could bring in lot of treatment, identifying a problem and then trying to have a good approach from the oral part of it would always be beneficial to the from the diabetic patient. See, that part is, see, most often we get to see a diabetic patient, I don't say the ratio, but we get to have periodontitis, diabetic patient with periodontitis. We are aware of diabetics and not aware of diabetics, but medical side, they always see their diabetic patients on a regular approach, and a lot of conditions they are made to see the medical people. So they need to have a good vision for all this to get into our mode of therapy, and at least give us a chance to help the diabetic patient, because a concern for the as a humanitarian service, we have to have this, and we get referred because vice versa is true from our side. But I feel there is a lacunae in getting referrals from them to us. I hope I answer this as an integrated approach.
Yes.
Yeah.
As far as our perspective is concerned, we definitely do refer our patients to maybe a physician or maybe a diabetologist when we see across a patient with some of these conditions. But then while we were going through the previous presentations, there were queries with regards to posed by these diabetologists that even if they refer the patient to a periodontist or maybe a dental surgeon for a checkup, then it becomes difficult to follow up with these patients, because some of the patients might visit, some of the patients might ignore it as well. So this is a practical difficulty as far as the vice versa relationship, which we do suggest to many a diabetologist or physicians is concerned. But then definitely this needs to be taken up on a more severe scale, and we need to have our efforts continued on this issue. And rightly so, we have this initiative started by Diabetes India organization, and hopefully with multiple such programs, multiple such webinars, or multiple such awareness initiatives by both of these organizations would be helpful in creating awareness amongst the physicians as well as the normal dental surgeon is concerned. Now, our next question, I would pose it to Dr. Selva Kumar, which would be in terms of means and modalities in which this awareness can be achieved. Maybe by an organization like Indian Medical Association, maybe RSSDI, maybe DI, maybe IDA, maybe ISP, or so many other organizations which are working on professional fronts. So what could be the modalities which can be taken up by these organizations in creating awareness amongst the respective members?
Thank you, Dr. Abhay. Abhay, sir, I just add up for the point what you asked for the previous question, integrated approach. At the medical college, the students, when they are posted in second year, third year, they have to be educated about periodontal disease and what are the various treatment options available. They have to know about that part of it. Then only we can have an integrated approach on this management of periodontal disease as well as diabetics. And second thing is they have to know the real causes of this periodontal disease. That education approach should be there. And regarding coming on to this particular question, how IMA, ISP, IDA we can have a joint programs like what Diabetics India Oral Health is doing. We can have a joint webinar, scientific sessions, and we can have the pamphlets for combining for both. And it can be, or we can have a social media videos which can be played in the reception area about the importance of oral health and this thing. See, the dentist can be the primary caregiver. They can be the primary doctors for this dentist. Most of the diabetic patients are diagnosed in the dental clinics. So the awareness of this oral manifestation of diabetes has to be included through this social media promotion and other things. The awareness has to be created to the general public. The general public comes for the regular dental visit at least once in a year, whereas they won't go to a diabetologist or other. So the Diabetic Society also should make sure that oral examination like optal and other things, they should make it mandatory that oral examination is a must. Even a general physician should be taught about the manifestation with the amount of intraoral cameras and photos we can have. They can take a snap and send it to the dentist, ask their opinion. Even that can be done. So for they have to educate the people that the good periodontal health or oral health is important for the good glycemic control. So IMA, IDA or ISP can do a joint programs and educate the general public about this.
I think Dr. Balaji has some query with Balaji, unmute yourself.
Yeah, yes, sir. No, sir, it's not a query. It's just to add on to what Dr. Selvakumar has said regarding educating members is all right. He also mentioned about educating the general public. I think whenever these camps are being conducted by IMA, IDA or whatever it is, I think the penetration towards the people or the general public in rural areas or even in urban and semi-urban areas is through non-governmental organizations who do a lot of social work and social service. So if you are tying up with these associations and then we are going into the general public with the pamphlets which we are making or doing a general camp, like for example, I'm telling all these Rotary Club, Lions Club, they do a lot of camps, activities they do. So just when they are having a eye checkup camp or something, these criteria can be added. Dental checkup camp also can be added. So it will go a long way in detecting and preventing these diseases.
I
Yes,
just
totally
wish to
agree
add
with
a
you,
point
Dr.
here.
Balaji. Yes, madam.
Dr. Balaji, that's a very good point. But whatever the means or the mode of trying to disseminate, but unless the physician takes up the call to make it happen for the patient he sees, it is just going to be just a dissemination of our knowledge. So that has to be made compulsory. How to make it compulsory and how a physician could be part of this will be the test of time. Because yesterday, I was just listening to the presentations from yesterday. So all of us are listening. They almost said the oral problems take the back seat. Okay, I agree with that. But nonetheless, if this could be helping a diabetic patient again, So if it comes from him, it is more authoritative, more authenticated, and the belief is more. And how to do that is a big question mark to all of us. And that is the decision making here. And you can't force it, but it has to come within themselves to help the diabetic patient.
So taking this query and suggestion to our diabetologist panelist. In fact, Dr. Saurav is with us. Dr. Bansi, for some reason, did not join.
Yeah.
But then I would want to pose this question to Dr. Saurabh regarding the integrated approach as far as management of both of these conditions are concerned. Is it relevant as far as diabetologists are concerned, or do they require further substantiation of this association?
Sir, what I think is that the association has been well established. An integrated approach is the need of the day, but somehow there's a gap in between that. I think so, whatever has been discussed right now, that the dentist, if he finds that the patient is having high sugars, is being referred to a physician or a diabetologist. But the physician usually doesn't take care of the oral health. He is more concerned about the complications which are being taught to them. These are microvascular and macrovascular complications. And if we see the textbooks and all that, there's a link that microvascular complication, nephropathy, neuropathy, cardiomyopathy, neuropathy, and retinopathy, and in macrovascular complication, stroke, heart attack, all these things are being taught. But oral health somehow is not taken, is taking a back seat. It is not in the front seat. And that's why it is not being practiced very commonly. Although there is in the back of the mind, there is a thing that we should refer the patient to a dental physician, or a dental surgeon. But the thing is that it is always being missed. And we take care of all the things, but we miss the oral health of the patient. Even if the patient tells to you that I am having these problems, some of the physicians might refer the patient to a dentist, to a dental surgeon, that go and check with the dental surgeon, because I'm not a specialist of this. But most of them, they are not referring the patient to them. So although doesn't needs any further that approach, that these modalities are to be taken care of, there should be integrated approach, but it is not being practiced commonly.
Okay, thank you, Dr. Saurabh. But then could it be a possibility of maybe stressing something more in the curriculum aspects, as far as when we go on to study the post-graduation in diabetes, or maybe physicians, medicine? Can it be made as a certain important aspect as far as diabetes management is concerned?
Yes, sir. Yes, sir. If we incorporate something like that, that if we are taught like that, then probably this will have a more impact than being told and discussed like this. Although it is integrated approach is required, but if it is being given to a PG, if it is being taught to a postgraduate or a MBBS student, that this is important aspect, then probably this will be taken care of more as compared to right now what we are discussing.
So this comes as a modification of syllabus which has been suggested by Dr. Saurav. It may not be a total modification, but then minor modification in terms of the curriculum.
With the integration of that.
Yes, integration of oral health in the curriculum as far as management protocols in diabetes mellitus is concerned. Now, I would pose this next question to our Dr. Vandana Madam. Do you think that having a collaborative or joint scientific sessions will help the cause of dissemination of current understandings and bridge the lacunae in management of patients?
Of course, that is what we are trying to do as a beginning of a chapter. And this would definitely help the collaborative or the joint scientific conferences. But again, I would like to pinpoint here, we are getting periodontists as a part of this team. we are trying to have more of the periodontal part of it and the diabetes part of it being connected and risk factors being common. But how about from the medical side? And that is where, having introduction to the syllabus is a human's effort, because it is not easy. Something to get introduced to the syllabus, it takes a lot of time. And then beyond that, always, earlier days, as I know, a medical student, a group of students used to come as their postings to dental department as early as 80s. But there it has stopped. They used to go to all the departments at least for 2 days. And that was an exposure to, at least that could be introduced from the medical fraternity, if not as a syllabus, as a call to make them understand. And next is these joint conferences absolutely are a need of the hour. They are the need of the hour. And implementation, it's not just that we speak and then we forget. See, oral health, whenever there is a patient who comes, I'm not talking about conferences, regularly when he meets a medical physician, there's always probably a questionnaire can be filled. Any oral health problems has occurred over the time, probably which was not there. Do you face anything? And list out all of them. And if they can mark it, and if the physician can see or the assistant can see, and that can go as a referral. We will solve a lot of problems. Simple issues, simple facts. But conferences and joint, as it's happening now, but the importance or the magnanimity of getting involved, you can try to have it here. We try to generate a lot of interest and the knowledge being catered, but it's again how to take up from the medical side. It's a very humble request that they have to take into consideration as a humanitarian approach to treat the diabetic patients where periodontitis is playing a vital role.
Yes, madam.
Yes.
Very rightly said. And I think Dr. Purnima Kumar has something to say, add on this. Dr. Purnima?
Thank you. Thank you so much. And this is such a wonderful discussion, and we really must be continuing this conversation. But I would say, let us step back. Let's start looking at gingivitis. By the time it's periodontitis, it is way too late. In the whole body, the oral cavity is the only place where bleeding is acceptable. Why are we normalizing this? I mean, if you had a cut finger, if you were bleeding from your finger, if you were bleeding from your toe, if you were bleeding from your eyes, from your nose, are you going to say it's okay?
Absolutely.
We need to start educating our medical colleagues about bleeding. This is the simplest, the most obvious, the earliest sign, and one of the most consistent signs of disease activity at any level. And if we can institute, and again, to what Dr. Vandana just said, having a questionnaire, do your gums bleed, in the medical office, and telling our physician colleagues, if you hear a patient saying my gums are bleeding, that patient needs to see us. That's it. End of story. So let's step back completely and, start really saying bleeding from the mouth is not okay.
Yes, totally agree with you, madam. And when we discuss these things with our medical colleagues, now one of the previous speakers has pointed, I think Dr. Anindita had pointed out that how is bleeding from the gums acceptable, and inflammation over the forearm is not acceptable. So these are really important aspects which the diabetologist or the medical practitioners need to think about and need to concentrate more on. I would like to seek comments from Dr. Saurabh on this aspect. Dr. Saurabh, are you there?
Yes, I'm there.
Yes, yeah.
So I think, sir, this will be a good approach. If we are doing like this, then probably it will create more awareness, and it will help the patient also, and it will help the collaboration also.
Yes, and in this, can we have a mandatory type of screening as far as for diabetes when the patient enters up into a periodontist setup, or vice versa? when the patient turns up into a diabetologist clinic, can we have an oral screening as a mandatory requirement?
Yes, sir, that can be a very good initiative. And as Dr. Bansi was saying earlier, that whatever pamphlets have been designed by Dr. Sangeeta in this has been released yesterday, can be a part of the regular pamphlets at the diabetic clinics, and those things will create awareness among the patients also. And patient, even if a doctor misses something, that patient can himself or herself go to a dental surgeon that I am having this problem because I saw this in the waiting room of a diabetologist, that I have seen this. And if he is filling up the questionnaire, then again he will be aware. Even if it is being missed, it will not be missed for the patient.
Definitely, sir. And I think Dr. Sangeeta has something to add on this.
Yeah, as we are talking about, Dr. Purnima also mentioned with regards to the screening modality for a clinician, physician. So we'll just make a mention here. There's something known as a clinician screening forms that we have designed, which is applicable both for the dental as well as a physician's clinic, which talks about what we talk about, the basic questions. Does your gum bleed? Do you have foul breath? Have you found that the basic questions that we have in a UG third year program that has been curated to have a insight from the physician side? If you see these, remarks coming as a question answers, that is the time you need to refer out. That is the time you pay an attention. So it's already made, and sometime we'll be releasing that document as well.
So, that will be a very good initiative, and probably that will create more awareness among the physicians also and among the patients.
Dentists as well, both.
Yes.
Both.
Exactly. Both sides.
Yes.
Because dentists are also equally unaware. I mean, we must take that initiative. Our dental colleagues are also unaware, because we guys are periodontists, we are a little more versed, but a regular dentist clinic is not aware that we can just vouch for that. So it's a universal awareness we are talking about.
It will be a win-win situation for all.
Exactly.
Yes,
For dentists also, for a physician also, and for the patient also.
Exactly.
Yes. I totally agree with all the panelists. Now, summing up our observations, what we have been discussing for the past 2 days, and at the end of this panel discussion, it appears that both the specialist and both the specialities are aware about the consequences of ignoring the other condition. And definitely, what is required at point of time is creating awareness, generating awareness amongst the members, because these are the members, these are the practitioners who would practice and go into the field and advise their patients or suggest their patients regarding the treatment which is required or the screening which is required, be it the periodontal patient wherein the screening of diabetes can be done, or be it the diabetic patients wherein the screening of oral health can be done. So this requires a coordinated efforts from both the specialities, and if both of them come together on a regular basis, maybe we would be in a near future in a position wherein we would have more number of patients being referred to a periodontist, to a dental surgeon for oral screening without having any complaints thereof. Now, I think there are some something to be added, some comments to be added by Dr. Purnima, and thereafter we'll go to Dr. Selva. First, to Dr. Purnima Kumar.
Thank you. This is great. This is a fantastic discussion. And I think, again, we have to expand our sphere of influence. Most of our patients do not see their diabetologist first. They see their general physicians first. So the message really we need to start bringing our physician colleagues, our GP colleagues into the conversation. And that is where these conversations have to begin. So bringing in the GPs, bringing in the dietitians, they have a great role in talking to these patients as well. And the GP is very quick to ask these questions, at least here. And even when I was practicing in India, I went to my GP for everything. Dr. Subramaniam, what is wrong with me? Dr. Subramaniam, this is the whole thing, right? So for me, the GP was my first point. And so yes, I'm very glad to see our diabetics colleague, diabetology colleagues in this conference, and it's wonderful to see them. But I really think bringing in the GP, even bringing in a pharmacist, into this conversation is going to be very, very key. So building these networks among all healthcare physicians is going to be very important.
So very well taken, madam. And most of the times, especially in the rural areas, it is the general practitioners who would come in relation to the conditions which we have been mentioning over the past 2 days. And he would be an important link as far as creating the awareness and generating patients for treatment, as far as coordinated treatments of both of these conditions are concerned. Over to you, Dr. Selva. You had something to add on this.
Thank you, Dr. Abhay. We were all discussing about how the disease management. My take on this is we have to see the disease prevention. Our focus should be from disease management towards disease prevention. So for that, dentists play a vital role. They can be the primary care providers. So for that, we in all the PHCs, we have to get the data with diabetic periodontitis complications and the relationship. We have to provide the data to the government, and we have to make sure all the dentists, or especially the periodontists, are posted in primary healthcare centers. For that, if we have some randomized clinical trial, whatever we see multi-center trial, we don't have it. Proper records, we don't have it. So if we have some collaboratory effect, like Sangeeta madam takes some effort, we can have it along with Diabetic Association. How many studies are there? The impact of periodontal disease on micro and macrovascular complications in diabetic patients. Do we have any study on that? Albuminuria, okay, there is some study. But what about the microvascular and macrovascular complications of diabetes mellitus? We don't have the data, and we have different ethnic group in India, different types of population. Are we having anything? And the same way we have different types of periodontitis condition, mild, moderate, and its effect on diabetes mellitus. We don't have it. So if we do a multi-center trial with proper education to the medical colleagues about the importance of periodontal, and we can request the government to post, and we can see lot of cases can, especially in the rural area, can be done. So this will be a step taking further. Second, the awareness. As you rightly said, Abhay sir, the polio eradication, the diabetic retinopathy has come down because of all the efforts of these social healthcare groups like the Rotary Club and other things. So something has to be done for the diabetic periodontal this thing also. So this will be the short group discussions will be of very good. Not only the scientific part of it, it has to be made mandatory with some clinical trials also. And moreover, periodontist should be, or any dentist should be, any dental examination should be part of this diabetic examination. Like routine, all the parameters they look out for, the oral examination is a must. So this is my take on whatever we have discussed it so far.
So both of these suggestions directly point towards our efforts being directed towards the primary healthcare centers, which are especially present in the rural areas. And these are the population, this is the population which is not in direct connect with maybe a diabetologist or maybe a physician. So we need to have coordinated efforts, not only with the diabetologist, not only with the general practitioners, but even at the primary healthcare centers in the rural areas, so that we generate awareness amongst the patients, amongst the general practitioners, amongst the primary healthcare centers, maybe amongst the social workers as well, because social workers are the main link as far as patients in rural areas are concerned. So taking this into consideration, we need to have coordinated efforts in this direction. So I would like to sum up over here.
Dr. Abhay,
yes,
I just want to add on here.
Yes, ma'am.
See, one thing that could be implemented is the lack of data in lot of aspects, Indian data. This could be a simple survey work. Survey is not simple, but at least you can conduct without much funding. If these can be floated online regularly once in 3 months, what is the diabetic and oral health aspect. Some of the, you can start with some of the programs, or you can initiate some of the studies, very simple studies, but give voluminous information to many people who are interested. And then this can be floated online as a, you have media now, which can be, you need not have to print. Consider this so that it can reach them and it can be available at all times. So once in, say 3 months is a good idea, or 6 months, it depends. This way, we try to create a data for ourselves, a big lacuna from the Indian scene. And publishing is a problem, a lot of charges and so many things. I don't want to comment on that because that takes a whole lot of hour if I have to discuss on that. So basically like a news, oral health and diabetic news, or you can name it what you want. And then it can be floated amongst the groups which are there, among the physician group and the periodontist group, so that, or the oral health group, you can have this done, so that probably that will add on to the learning mode and then creating an awareness within ourselves and a good data collection. Okay, this is what I would like to say, because there usually, see, when who is interested will fall upon that. Otherwise, they don't bother. It's okay. There are people out of 10, even if they 5 of them go into that, our job is done. Right. Our job is done to create awareness amongst others and make them know that this is happening and this is the data which we have collected. So that's what I would like to have it as a media which is useful to us, can be utilized for this. Thank you.
Very valid suggestion, madam. Not only the diabetologists, not only the practitioners, but then even the general public needs to be made aware of about this conditions. And I would say survey, you had spoken about survey, and survey about both of these conditions is an idea which is very dear to Sangeeta. And I think she has been after many people with carrying out this survey. And I would request her, yes, I would request her to have some comments on this.
Oh, it's like customizing on our own levels is fine, ma'am. It's absolutely great. Trying to pitch in, as Dr. Selva Kumar says, government bodies, Indian government bodies are very, very, very red taped ones. So let us not even think of entering those zones unless someone has got some push and pulls. So
no, I don't. We'll not go to the government level at all. We
at our levels, it's okay. Amongst
that's what I said.
It's okay.
See, we have to reach ourselves first.
Somebody who wants to bang his head in the government of India, please go and do it. I'll be more the happiest person to advise.
You should. Sangeeta has banged enough of her.
Oh.
No, yes, no, you don't have to do that because you're going against the storm. I don't think you have to do that.
It doesn't
go
work.
Be at the ground root, root levels, we say, and then be at it. And our job is to cater the information. How to do that you can plan.
My only thing I'll add here is making guidelines, putting into journals and documentation. The buck doesn't stop. It is just a small drop in the ocean. What we are talking now needs to go further.
Yeah, journals you should not, because journals are only favorable.
What I'm saying is adding just a guideline does not help. That guideline is just a small line. It has to be drawn as a big map.
Things have to be implemented.
Exactly.
Yeah, that's what I said.
After the publication, things have to be implemented. What
problem is the buck stops there. Okay, guideline publish ho gaya, now we sleep too. It doesn't really help. It doesn't really help.
Sangeeta, don't publish, but you float it. You keep floating it.
I'm just saying, adding a thought. So not the guidelines at work. Guidelines just a roadmap, and then you have to take it forward. And that's what we are sitting and discussing here for.
We are discussing here, and then data being not there at all, we are discussing on others' interests.
Exactly.
That is what I am always concerned. I always say, have the Indian data first for yourself. With so much of a growth in education, and we have a lot of types to float our information, you can do that. That's what I'm saying. Don't go for, because we always depend on others, whatever they have worked, because they can do a lot of things. But where can we do that? It's not possible. We don't have funds. We don't have facilities. We don't have anybody to support. It's only a minimum data that we create. But let that something which can be. It's not beyond us to do that. Yeah, that's what.
True.
Dr. Abhay, can I put a thought
Concluding the
across?
observations of all the panelists, I would say that integrated efforts are definitely required in this direction. And the integrated efforts need to be done not only by a single specialty, but it has to be an all-round effort, be it the general practitioner, be it the physician, be it the diabetologist, be it the periodontist, be it the dental surgeon, or be it any specialist, or be it the social workers even, or the healthcare workers who are working in primary healthcare centers. So unless and until we are integrated in our approach, we would not succeed what we see in the appropriate management of diabetes, or for that matter, even the appropriate management of periodontal disease. So thank you all the panelists for being over here, expressing your valuable suggestions, and all the audiences who have been watching this deliberations on social media and YouTube. So thank you all for your interest in this subject. And lastly, I would also like to thank Diabetes India for having such a wonderful initiative on such an important topic. Thank you.
Thank you, Dr. Abhay, for conducting this panel discussion in a very, very efficient and very interesting way, and all the panelists and the co-faculty who have joined in. So with this, I think we should be summing up the webinar series, and I must end it with a comment: coming together is a beginning, keeping together is a progress, and working together is a success. So we look forward for more joining hands with the organization, and greeting you over. So anybody who wishes to join is more than happy to be a part of the Diabetes India Oral Health Group. We'll be happy to welcoming you all, because together we grow, and that's what we believe in. So with these notes, I will just make a quick comment. All the delegates who have joined for this webinar can download their participation certificates after the webinar about 2 hours later, because that's the time where the login links will be active. And to all the participating faculties, will be sharing and emailing your participation certificates. And thank you so much for being a part of the show. Dr. Sumedha, would you like to add a note?
Before Sumedha, I just want to add a note to you.
Yeah, ma'am, please.
Proud of you, Sangeeta, for being mainstream and, trying to have us all connected, and you're doing the best. Thank you so much.
Thanks for your blessings, ma'am. Your word of guidance has always been there, and that's
always.
What
it's always there. It's virtual, always there. And thank you, Dr. Bai, and Balaji, Srihari, and Dr. Selvakumar. Thank you so much. It was a fantastic platform.
Thank you.
And one more note I would like to make here, Dr. Purnima, ma'am. It has been great to have you here. She is busy penning down notes, I can see. And ma'am, it's so nice to see you for participating yesterday and today. And it's truly an honor for this group to have you over, ma'am. It was really nice to see you, ma'am. And
great initiative.
Great initiative, and really we would like to take your advices. Maybe in the future, some way you can be of great advice to us, and
let me know how I can help. Let me know how I can help. I'm always here. Happy to be part of the group, and happy to participate and do what needs to be done. Let's do
it. Absolutely, ma'am. Yeah, Dr. Balaji, please.
Yeah, just thanking everybody, especially DIOH, for being and getting along with us to discuss these things. And thank you to Dr. Purnima and Dr. Dominica also, who have joined us from abroad. Thank you very much.
Thank you all. So we sign off from now. Can we do that?
Yes.
Till we meet next. Yeah. So good night to all, and we catch up again soon. Thank you so much. Thank you.
Thank you, Dr. Purnima and Dr. Dominica.
Thank you, Dominica.
I didn't do that. Thank you all.
Thank you so much.
Thank you, Srihari.
Bye-bye.
Thank you, ma'am.
Thank you, IT Events. Thank you, Kushal, for being a big support. Kushal, are you there?
Yes, ma'am.
Thank you so much for being the tech support for the 2 days, and it's been great to working with you guys. Thank you so much.
Thank you.
Srihari, are you still working in the army?
Yes, ma'am. I am still working. I am in Delhi now.
Okay. That's great to hear. I think one of the.
I'm the HOD in Army Dental Center here.
Oh.
Sir, can I break the news?
Yeah, sure.
Sir, Madam Sir is being promoted as brigadier and he will take charge from 1st January at headquarters, Delhi.
Oh,
thank you,
excellent.
Congratulations, Dr.
Happy
Srihari.
growth.
Congratulations, Dr. Srihari.
Happy information.
Thank you.
Very nice.
Congratulations.
Yes.
So you're still post-stationed ADC,
I
sir?
will be in Delhi only.
Wow, good.
Headquarter.
You were at Pune, right? Srihari, you were at Pune.
I was in
Delhi,
Pune,
ma'am.
yes.
Yeah.
I was in AFMC.
Now he is in New Delhi.
AFMC, I remember.
Right.
You had contacted me for my
for the exam.
Yes.
Right.
I remember the compliment that you gave me. I still remember your name. Thank you so much. Thank you.
Great. Thank you, Dr. Abhay.
Thank you, Dr. Have a nice time.